Good morning and good afternoon. My name is Tracy Cook, and I'm with Sachs Healthcare Communications. I'd like to show our audience today how to send in your questions, which our speaker will answer as many as possible at the end of the presentation. Please type your questions into the questions box. You can also download the handout from the handout section of the GoToWebinar control panel. Our moderator today is Heather Davenport. Heather has been a critical care nurse for 25 years. She was a clinical nurse educator for 3.5 years and recently promoted to the director of cardiac step-down at Cookeville Regional Medical Center. Heather has worked with the CVICU, cardiac step-down, and cardiac outpatient procedure units. Additionally, Heather provides clinical education for staff in all aspects of medical and surgical cardiac care, including Impella, IABP, CRRT, arrhythmia, and hemodynamics in multiple modalities and technologies. Heather is also president of our local AACN chapter. Welcome, Heather.
Good morning and good afternoon, everyone. Thank you, Tracy, for such a kind introduction. The title of today's webinar is The Road to Improved Ventilation Quality. We are privileged to have two highly knowledgeable experts, Josh Collier and Kevin Joles, addressing this crucial topic today. Josh Collier is currently Assistant Chief of EMS, South Metropolitan Fire Protection District, and Raymore, Missouri, with over 22 years of service. In 2021, Josh earned his MBA at Waldorf University in Iowa. Josh has taken on leadership roles that focus on helping emergency medical service employees learn and succeed in a stressful career. Kevin Joles is an experienced and dedicated fire service professional with nearly 29 years of leadership in various operational and strategic roles. He is currently Division Chief, EMS at Olathe Fire Department in Olathe, Kansas. He is a member of the International Association of Fire Chiefs and is chair for 2024-25. Kevin has spoken at several EMS conferences, regionally and nationally. Disclosures: Kevin Joles is on the Zoll Speakers Bureau. Josh Collier has no conflicts of interest. Continuing education for nurses and respiratory therapists. This educational activity is approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of the webinar. The accreditation statements are as noted below. Support for this educational activity is provided by Zoll Medical Corporation. And now I'll turn the presentation over to Kevin Joles. Good morning, Kevin.
Good morning, everybody, and welcome to this presentation by Josh and I. We appreciate your attendance. First of all, I just wanted to just get started by saying I'm out of town and I'm in a hotel, and I think I've warned the hosts of this, but if there's any loud noise in the background and by a really busy street, I'll try to mute and come right back. Try to advance here. There we go. Like Heather said, Kevin Joles with the Olathe Fire Department in Kansas and the International Association of Fire Chiefs chair. Today, the learning objectives are going to be discussed the clinical benefits of real-time ventilation feedback in cardiac arrest management, describe the practical methods for deploying and integrating ventilation feedback into frontline care, and list the tips for incorporating ventilation feedback metrics into debriefing sessions to enhance quality assurance and continuous quality improvement in cardiac arrest responses. So what happens when we ask the internet on how well we are ventilating? Quite honestly, the answers are not the best. Some studies are out there that show providers frequently overventilate the patients. Of course, we know that everything on the internet is true, right? So when I did ask how good we are, these are some of the things that came up. Proper ventilation can significantly improve patient outcomes. That's probably somewhat obvious to most of us. Excessive positive pressure ventilation impairs circulation and CPR effectiveness, and hyperventilation worsens cardiac arrest care survival rates. So some of the ventilation basics, I truly believe that ventilations are the new chest compressions. Ventilations is the B in the ABCs and is fundamental to resuscitation. We know ventilation is essential. We know hypoventilation leads to hypoxia and CO2 buildup. And we know that hyperventilation during cardiac arrest causes gastric insufflation, aspiration, and intrathoracic pressure, increased intrathoracic pressure, which reduces venous return. Yet despite all this, ventilations often receive far little notice or attention. So the AHA guidelines, in the guidelines, it says avoid excessive ventilation. It says to be ventilating between 500 and 600 milliliters. Talks about 30-2 compression ventilation ratio. The origin of this number isn't rooted into any extensive scientific research, but rather just expert consensus. And as there are no human studies specifically validating the 500 to 600 mil ratio. With an advanced airway in place, we have such as a supraglottic or endotracheal tube. Guidelines recommend delivering 1 breath every 6 seconds, equating to about 10 breaths per minute. Therefore, depending on the compression rate, the ventilation rate typically ranges between 8 and 10 ventilations. So the focus on tidal volume and ventilation strategy is gaining more attention. And as we move through the 2020s, there's a growing discussion about whether ventilations could possibly become as central to resuscitation as chest compressions are. Between 2010 and 2020, extensive work, particularly through the Resuscitation Outcomes Consortium, or ROC, was done to improve chest compressions quality, demonstrating that optimizing depth, rate, compression fraction, and minimizing shock pauses significantly improved out of hospital cardiac arrest outcomes. However, much of this work is primarily focused on compressions. Now the conversation is shifting towards airway management and ventilation during cardiac arrest. Research continues to explore the effectiveness of different strategies such as a bag valve mask, supraglottic airways, and endotracheal intubation, while also considering the ideal ventilation rate and tidal volume for optimal patient outcomes. Understanding how ventilation impacts survival, particularly in cases where hypoxia is a major factor, will be key for refining resuscitation guidelines moving forward. When it comes to ventilation, during CPR, we still have more questions than there are answers. How much oxygen and how much ventilation do we really need? And how strong is the evidence supporting different ventilation strategies? Is there a best rate, volume, or pressure for ventilations? Some research suggests that the number of breaths given per minute could affect survival, but we're still figuring out the ideal approach. Should we also be focusing on oxygen and carbon dioxide levels during resuscitation? The jury is still out. In Toronto, researchers have studied end-tidal CO2 to see if it can help predict which patients are likely to survive. And some studies suggest that if the end-tidal is very low, the chances of survival is very low as well. Others have looked at whether high end-tidal levels improve the chances of survival and defibrillation, but it really depends on how the airway is managed. One challenge is the end-tidal readings are less reliable when using a bag valve mask, and even with an advanced airway, there's still uncertainty. While we've learned a lot, many questions remain, and more research is needed to truly understand the best way to manage ventilation during cardiac arrest. So as we were sitting in a hotel getting ready to teach a few years ago, we looked up at the TV and we saw this in the lobby in the hotel. We just saw this type of ventilation occurring. Now, we don't know exactly what happened, but as we work in the fire department, we do a lot of training. We do a lot of CPR training. We do a lot of cardiac arrest as a whole training. Ventilation seemed to kind of lack on the concentration of exactly what's happening. But as you can see here, this is very easy to do. It's very easy for us to do, and no matter what the environment is, whether we're in the hospital or we're in the streets, paying attention to the tidal volume, paying attention to the ventilation rate, it's always difficult to do. So how good at ventilating patients do we think we are? And unfortunately, it's embarrassingly terrible. A lot of the evidence shows that we overventilate, we underventilate with tidal volume. It just depends on what bag we're using. The correct incorrect technique, it just drives us to poor performance. So some of the consequences of hyperventilation in CPR is giving too many breaths during CPR can stop the chest from creating a negative pressure when it recoils, which is needed to pull blood back into the heart. Research shows that faster ventilations raise pressures inside the chest, lower blood flow to the heart, and increase blood acidity, but do not improve oxygen levels. Hyperventilating without realizing it may be one reason survival rates for cardiac arrest are still low. Too much positive pressure can make CPR less effective by reducing blood volume to the heart and weakened resuscitation or weakened circulation. A study by Charles Deacon and his team in Britain looked at how patients in cardiac arrest are ventilated in hospitals. Their findings show that hyperventilation is common, mostly due to fast breathing rates and other large breath size or large tidal volumes. They found that the average breathing rate was much higher than the current recommended, and tidal volumes and overall intake per minute were also higher than ideal. Additionally, the airway pressures remained high, which could negatively impact blood flow during CPR. Although guidelines for breathing rates exist, the study suggests that in real-life situations, they are often not followed. The results highlight the need for better ventilation during control during resuscitation to improve outcomes. So we can see here during this study, the median respiratory rate was between 9 and 41. And these are folks that were actually being tested. They knew that they were being watched. The median tidal volume was 619, which we're shooting for 450 to 500. Median minute volume was 13 liters a minute. Median peak respiratory pressures were 60.6 water pressure, and then the positive airway pressure was 95.3%. So another study evaluated ventilation quality in adults undergoing in-hospital CPR. Here you can see that the mean ventilations were 21 breaths per minute, more than twice the AHA recommendation shown by the red line here. Mean tidal volume was too high at 619 mils compared to the AHA guidelines of 550. And as a result, the mean minute ventilation, which is the ventilation rate times the tidal volume, was 13 liters per minute compared to the AHA recommendation of 6 liters per minute. The authors concluded that hyperventilation was common, mostly due to high ventilation rates, and that even though the guidelines are all well known, it appears that in practice they are not followed. So if we know that it's important, why are we hyperventilating patients in cardiac arrest? So is it because the inexperienced providers, the lack of cardiac arrest or advanced cardiac life support certification or ACLS, periodic auscultation to confirm the airway placement, or CPR delivered at off hours on nights or weekends? So depending on the day, and that really doesn't change much for us in the on the pre-hospital side as we are getting woken up or we're going from call to call. How aware we are about what's going on because of sleep deprivation or fatigue often determines how we deliver some of our skills, no matter what certification or genre that we hold. So manual ventilation is probably the most complex skill that providers perform. However, it's often forgotten. It's most likely looked at as a very basic skill that we don't ever have to practice. We worry more about the algorithms that we follow, the drug dosing, things like that. As basic as this is, it's very critical. So it's a very important skill, like I just said, however, often forgotten. Critical that we perform well in medical and trauma patients, regardless of how the patient looks or feels. We need to be able to perform well, and hard to do even using a two-handed seal with 2 providers. Some other things that make it difficult are provider hand sizes vary widely. Multiple grip techniques are used, so the CE versus the CO method. Skillful performance often feels monotonous, leading to inattention. We start to get distracted. Some of us want to pay attention to what drug dose is being pulled up, or are they going to shock somebody, or we're trying to run this call from the ventilator seat, and it's just difficult to do and stay attentive. Equipment lacks standardization across services. Airway adjunct selection, whether it be an OPA or an NPA, differs case by case. Failure to utilize available tools and tidal volume being delivered is often uncertain. And all of our patients are different. Every single one of us has a different face type, whether we have facial hair, things like that come into play. So anatomy changes with altered mental status. Things start to fall back into the body as opposed to stay firm and tight. Patients who are agitated or resisting care, difficult to manage. Challenges associated with obesity or advanced age, presence of facial hair, like I said a couple of times now, missing teeth or use of dentures impacting airway management, injuries to the face or upper airway complicating interventions, and then air entering the stomach instead of the lungs, creating gastric insufflation. So the SpO2 and the end tidal are supposed to guide us, correct? Sometimes that's what we think, and we start to pay attention to some of this, but in all reality, a lot of that, it starts to deter from what we're actually seeing. So we shouldn't be counting on it. Pulse oximetry is lagging because of lagging response with the machine. Sometimes can be affected by perfusion, vibration, skin color, how cold or warm it is outside. The capnography sometimes is more complex than we realize. The relationship between ventilation and perfusion, side stream versus mainstream, sensor placement, and the airway stack. And so over time, in the recent past, maybe over the last 7 to 8 years, we've been adding a lot of things to the airway stack, which doesn't take away from their effectiveness. It just has to be managed differently. So we're paying attention to this stuff a lot more. So how are providers preventing hyperventilation, and how are we improving how we ventilate? So we're focusing on training more than we ever have in the past, higher compression to ventilation ratios, metronome guided ventilation. So there's apps that are out there that we can play. Some monitors have metronomes on them. So like we actually have a metronome on our monitor to help us with either chest compression sometimes, and so that we can hear it a little bit. Sometimes these scenes get chaotic, especially in the hospital rooms when there's a lot of providers in there. It gets difficult to hear. Ventilators are sometimes used in cardiac arrest and airway management in emergencies, and ventilation feedback devices. And so if we forget to turn on the apps and the device aids, or the environment is too loud to hear them, we start to fail and patient poor ventilations follow. So audio-visual feedback, it's the use of a structured resuscitation training combined with real-time audio-visual CPR feedback during out-of-hospital cardiac arrest was independently linked to enhanced quality of chest compressions, higher rate of patient survival, and better neurological and functional recovery outcomes. The use of audio-visual feedback during CPR led to improved outcomes. So you can see here a study from Dr. Ben Barbaro studied survival to discharge for 484 consecutive cardiac arrest patients before and after deployment of a CPR feedback device in combination with scenario-based training. So as you see here on the orange column, the compression rates were 128. This is before the training. The depth was 1.78 inches, so just short of 2 inches. Pre-shock pauses were in the nearly 27-second mark, and CPR fraction was 66.2%. After the training, went down from 128 compressions to 106, so a 17% change, 1.78 inches up to 2.15 inches, and a reduction in pre-shock pauses from 27 seconds to 15.5 seconds. And then the CPR fraction went up tremendously from 66 to 83.7%. So this study also revealed that with the help of CPR feedback, you had a nearly a 3% chance of good function after a cardiac arrest, and nearly 4% when this was a witnessed shockable rhythm. So real-time ventilation feedback to improve ventilation quality, it provides targeted and delivered ventilation volume, targeted and delivered ventilation rate, a ventilation quality indicator and countdown timer to guide providers to deliver high quality ventilations. And ventilation feedback works with any standard size commercially available airway management device for both intubated and non-intubated patients. Ventilation feedback can integrate with existing audiovisual CPR. Monitor defibrillators can offer both audiovisual CPR feedback and ventilation feedback, giving providers simultaneous real-time feedback on both CPR and ventilation quality with manual or mechanical CPR. So ventilation feedback can be used. Oops, sorry, here, I just got a little ahead of myself. So on the left here is a dashboard that allows us to see some CPR feedback as we're working the cardiac arrest, which is very helpful to keep us on task for compression depth and rate and quality. And then on the right-hand side here is the BVM tidal volume measurement that allows us to be able to focus on making sure that we're not overventilating or underventilating, and that our ventilations are given on time and appropriate tidal volume. Ventilation can also be used in QA/QI. It's a great tool to be able to pull your team together after the cardiac arrest or any type of call that you've used the devices on, to be able to go back and review via QA. The debriefing session after these opportunities has been very helpful with our crews in the pre-hospital setting. As long as you go in there with a non-punitive, non-judgmental attitude, you're able to really use that QA quality feedback to enhance the next time, so our folks can feel confident that what they did this last time may not have been as perfect as they assumed it was. We often ask, how did this go? They say, oh, it went great. And then we show them the minutes of time in which we were off the chest or not breathing or inappropriately breathing for a patient. Do we need ventilation feedback? It's well established that excessive ventilation is often provided to patients today. We've proven that a couple of times with some of the studies we've shown earlier. Guidelines recommend that we deliver tidal volumes that correspond to a visible chest rise to 500 to 600 mils. And providers can distinguish chest rise on anesthetized volunteers. Mean tidal volumes of 181 mils and ventilations were perceived as adequate when tidal volumes on average exceeded 384 mils. So what that's saying is we might start to see the chest rise at 181 mils, and some people may think that that's adequate, all the way to the point where we think that it's the ventilation has been adequate because we're squeezing the bag even more, but we're only getting to about 384 mils when we really need to be up in the 400s. So what does the research say? Manual ventilation quality is improved with a real-time visual feedback system during simulated resuscitation. So the purpose of this study was to determine whether the study was aimed to assess whether a real-time visual feedback tool for ventilation rate and volume could enhance the quality of manual ventilations during simulated cardiac arrest scenarios. So the methodology was pairs of emergency medical technicians, or EMTs, conducted 2 8-minute sessions of CPR on a mannequin simulating cardiac arrest. One EMT was responsible for delivering ventilations while the other one performed chest compressions. In the findings, the implementation of the visual feedback system significantly improved the proportion of ventilations delivered within the recommended rate and volume ranges during simulated resuscitation. So how does it work? So in 2024, Dr. Drennan, a paramedic scientist at the University of Toronto, has presented a before and after study that demonstrated the value of real-time feedback during ventilation. So the objective of this study was to determine whether the real-time feedback improved compliance with the predefined targets of ventilation rate and volumes during the out-of-hospital cardiac arrest. And the use of real-time feedback was associated with an increased proportion of ventilations that were compliant with the predefined targets during cardiac resuscitation. So introducing ventilation feedback into patient care. This is where I'll bring my colleague here, Josh Collier from South Metro Fire District here, our neighboring state to the east. Take it away, Josh.
Thank you so much, Kevin, and thanks, Heather, for having me on today. So there were some good topics there that were discussed, and I want to just go ahead and build on what you already talked about and present some real-time data from patients that we've actually ran before. So like you said, my name is Josh Collier. I'm the EMS chief of South Metro Fire in Raymore, Missouri. And you may be asking yourself, what can a paramedic teach me about ventilations? I mean, ventilating a patient isn't that difficult. Well, that's exactly what I thought. Then we started utilizing a feedback sensor, and we started to discover that it's not as easy as we all thought it was. So that's what I'd like to cover. We're going to go over the basics of why we started utilizing a ventilation feedback device, how easy it is to set up and start using, and then we're going to go over actual data from real patients with a feedback sensor device. Let me get this to advance here. Hold on one second. All right, jumping right in and how we started this journey. We started to look into the statistics regarding our cardiac arrest patients. As most of you are well aware, when we started looking into the statistics and trying to compare all the different data from all of our patient contacts, we quickly realized that no two patients are the exact same. No two scenes are the exact same, and no two care providers and their crews are the exact same. And each patient presents their own unique variables that are outside of our control. So what this is a call back to the basics. What can we do as healthcare providers to eliminate inconsistencies and variables in the skills that we provide? So when we look at our cardiac arrest events, there's two major tasks that have to take place, and those are the ventilations and compressions. The other day I was reading a book and I heard a cool concept that made me think, and they said that principles never change, but methods always do. That's principles never change, but methods always do. So the methods we use change, but the core principles don't. So when we look back to the changes to cardiac arrest over the last 20 to 30 years, there's been changes to some of the methods. We used to give lidocaine as an antidysrhythmic. Now we give amiodarone. We used to give dopamine to increase the blood pressure. Now we give Levophed. We used to intubate absolutely every patient. Now we started using supraglottic airways. So some of the methods have changed over the last couple decades, but the core principles of ventilations and compressions, those have not changed. And that's what we need to get back to, providing consistent results for our patients. So these are the two major skills where we need to eliminate any inconsistencies and provide excellent care for our patients. This is where utilizing a ventilation feedback device to monitor the ventilations can help us reduce the amount of errors and help us create a repeatable skill for all of our patients from all of our care providers. I mean, think about it. If we were on a cardiac arrest event a week ago and we have a paramedic who is accidentally hyperventilating the patient throughout the entire scene, obviously that's not good for our patient. So that's why we're wanting to collect the data and make sure we're being consistent from all of our care providers. Let's be honest, we've all been on a cardiac arrest patient and our adrenaline starts pumping. It's easy to start hyperventilating the patient at a faster rate than we should. It's easy to start squeezing the bag a little more than we probably should. Or we start thinking about other treatments and what else is going on. This is where a ventilation feedback sensor can help us provide the consistent care and help us improve our outcomes. So just going over the basics, we're going to talk about what is a ventilation feedback device. And basically it's just a sensor that connects onto the BVM and it gives a breath by breath measurement of the rate and the tidal volume and displays the data on the EKG monitor for the healthcare worker to see. It prompts the healthcare provider when to provide the next breath, and it provides real-time feedback of the tidal volume that was given. So like Kevin mentioned, you may be asking yourself why. I mean, it's not difficult to give 10 breaths per minute and watch for chest rise. Well, there was a cool article published a few months ago, and they did a before and after comparison that challenged healthcare providers to provide the best rate and the best tidal volume without a ventilation feedback device, and then with a ventilation feedback device. As you can see on the graph on the right, there was a stark difference between the two. Without the feedback device, the rate was only correct 41% of the time, and the volume was only correct 31% of the time. So in other words, half the time we got the rate wrong, and 2/3 of the time we got the volume incorrect. But then when they started utilizing a ventilation feedback device, the stats jumped dramatically, and the rate was corrected to 71% of the time, and the tidal volume saw the biggest difference and was correct 79% of the time. These are the inconsistencies and variables that I mentioned in the beginning that we need to start eliminating as healthcare workers. In this slide, there's a picture on the left, and that's just a picture of a ventilation feedback sensor. This happens to be the Zoll AccuVent sensor. And all it does is it plugs into an existing cable on your EKG monitor. And I'm going to play a video here for you. Get it going here. And this just demonstrates how easy and effective it is to set up. This is paramedic Mike. This is him opening up the monitor, getting out the cable that's already pre-connected onto the monitor. He opens up the packaging of the ventilation sensor device, and he simply connects that onto the BVM and onto the simple face mask. And then here's the cool thing. There's no buttons to push. There's nothing to turn on. With the first squeeze of the bag, I'll zoom in here on the monitor, and you can see the information comes up at the bottom. There on the left-hand side at the bottom, that's the volume that was squeezed through the bag. There in the middle of the bubble, that's the countdown timer, when to provide the next breath. And there on the right, I believe it says 9, I can't see it very well. That's the breaths per minute that were delivered. There's a little more of a zoom in. Each of those are configurable. So the volume, if you want to increase the volume or decrease the volume, you can change that depending on your patient's size or what the patient needs. If you wanted to increase the rate, you can increase the rate or you can decrease the rate. So the cool thing about this, like I mentioned already, there's no buttons to push, there's nothing to turn on. With the first squeeze of the bag, the information displays on the monitor. So if I can get the firefighters and EMTs to do it, I mean, I'm sure you guys can do it just as well. Moving on here, talk about the implementation process. So because the ventilation feedback device is so simple to use, the implementation and training process was relatively easy. I got a lot of buy-in from the guys because it was so simple to use. So at the time of implementation, we didn't actually change any of our existing protocols. And as the EMS chief, you're always thinking about how much training will need to be done and how many protocols will need to change for new equipment. But with that being said, because it's so simple, we've had nearly a 100% use rate when the ventilation feedback sensor is indicated. The ventilation feedback sensor can be utilized with several different types of airway devices. It can be utilized with the BVM and simple face mask like you saw in the video. It can be utilized with endotracheal tubes, different types of supraglottic airways. We use the iGels, we don't have any problems with it. And it can also be used in conjunction with other sensor devices like end-tidal carbon dioxide. So here's another video of Mike. He's gonna just do another demonstration of the setup. And basically this video just demonstrates how easy it is to set up, and there's really nothing to mess up. It snaps and it swivels into place. There's no way you can get it backwards, flipped around, and disconnected in the wrong way. This is him trying to use it the wrong way. It goes right onto the BVM. And like a lot of other airway devices, it only connects one way. All right, now that we talked about what a ventilation feedback sensor is and what it measures, we're going to transition into some real patients and see how we use the information for the training and quality assurance process. So we're going to be viewing the ventilation feedback sensor on our quality assurance software, but I want to stress you don't have to have this QA/QI software that we're going to be viewing for you to utilize this on a patient. The information is going to present just like it did on the videos that I showed you. However, if you want to look at the data after the fact later on and review it, you're going to have a QA/QI software that integrates with your monitor and the device that you use. So looking at the slide, you can see the average ventilation volume in the top right-hand corner. And there's a graph in the top segment for each ventilation that was given. In the middle, there's a section that gives the ventilation rate. And then at the bottom, you're going to see the end-tidal carbon dioxide. Now, just as a reminder, the ventilation sensor does not measure carbon dioxide, but we're going to see this information here in this slide, okay? So initially, I like to give it a quick overall glance, and I like to look at the duration. You can see here the time starts at about the 6:57 mark, and the total incident lasts about 25 minutes. You can see at the top, there could be some room for improvement in the tidal volume at only about 52% that were between the 400 and 500 mil range. But overall, you can see the average ventilation volume for the entire duration was 480 mils, so that's pretty good. Next, you can see the ventilation was right on target at 87% of the time. There are some inconsistencies. That's the last circle that came up when the patient was transitioned at about the 7:12 mark. But overall, the ventilation rate was really good for this patient through the duration of the scene. So this is a view of the data the ventilation feedback sensor provides for the quality assurance and quality improvement process. And you can see how beneficial this information can be for all your patients. Now, to provide you with a little bit of background on this call, the healthcare provider who gave these ventilations had been on the job for only 2 weeks. And this was his very first cardiac arrest where he provided ventilations on a real patient. So utilizing the feedback sensor, he focused on the monitor and he followed the prompts. Of course, he was looking for condensation and checking for chest rise like he normally would, but he also followed the monitors and the information the sensor provided, and he did a great job. So this goes to show you can have a relatively new provider who provides consistent results throughout the duration of the code. This is another case, and you can see the time starts about 17:49. And it lasts well past 18:25, so that's over a 35-minute duration. In this scenario, we had multiple crew members providing ventilation throughout the duration of this event. The average volume in the top right-hand corner was right on target at 451 milliliters. And like I said earlier, all these numbers are configurable, so they had it set at 450 for this patient. And the ventilation rate was good for the most part. There were a few random ventilations at the beginning, but overall the providers did a good job. But I use this slide to show you that you can have a relatively long scene time and provide consistent results with multiple healthcare providers throughout the duration of the event. So when I do a review, I know this patient had good ventilation rate and a good volume throughout the duration, and this helps with the quality assurance and training aspect to make sure we're being consistent. Now to move on to some inconsistencies and areas of improvement. I was a little bit hesitant to add these slides because I didn't want to make anybody look bad, but let's all be honest, we all have room for improvement. And to be honest with you, I probably did this at one time too. So first off, in the upper corner, you can see the average ventilation volume for this patient was a little bit on the low side at only 395 milliliters. This may have something to do with why the patient's end tidal kept raising throughout the duration of the event. But now with utilizing a ventilation feedback sensor, we now have quantifiable data and we can make improvements for the next patient. I can go and have a conversation with the crews and we can do additional training. Then if you look towards the end, there's some obvious hyperventilation of the patient occurring. Now, we do not encourage or teach hyperventilation or hyperoxygenation for cardiac arrest patients for all the reasons Kevin mentioned earlier. It increases intrathoracic pressure, it hinders blood flow back to the heart, it can cause barotrauma, it can cause lung damage, and even hypotension. So after doing some investigation and asking the crews why there was such a dramatic change in the ventilation rate, we discovered that this was a patient transfer to the emergency room staff. The staff didn't know there was a ventilation feedback sensor they can be utilizing, and this was the effort they did. But I believe this slide proves that the study presented at the beginning is accurate. We think we're doing a good job. We think we're doing the correct rate and the correct volume, but the objective data from the sensor is telling a different story. Providing quality ventilations with the correct rate and the correct volume is harder than we give it credit for being. It's easy to lose focus and start concentrating on other tasks, and then we get results like this. This is like the video that Kevin saw earlier. They're just squeezing the bag. That's a rate of almost 30 times a minute. And then this is the last patient that we're going to review, and it's about the same deal. The tidal volume is better than the last patient. Things got shifted on that one, but everything looks good at the beginning, and you can see a specific moment in time when the ventilation rate changed dramatically and the patient started being hyperventilated. This again is a patient handoff situation. We know this is detrimental for our patients. Can you imagine this happening throughout the duration of the entire event? Unfortunately, it's probably happened before, but now we have better technology that can assist us. So the bottom line is we use this information to help provide better patient care. And we utilize a ventilation feedback sensor. We can start collecting actual quantifiable data about how we're performing as healthcare providers and try to eliminate these variables and inconsistencies for our patients. So in conclusion, I just wanted to go back and cite the article that I mentioned in my earlier slides, that a before and after comparison found real-time feedback had significant improvements in the compliance of ventilation rate and volume. I think the patient case reviews that we showed you have proven that the ventilation feedback sensor improves our compliance. And lastly, it's easy to use and it's easy to implement. The ventilation feedback sensor helps us eliminate the inconsistencies, therefore helping us improve our patient outcomes. And then the last and final point is, it's 2025. If we're not using technology and collecting data now, then when are we going to start? We have the technology to create quantifiable data and objective data from our principal skills in cardiac arrest patients. And it's time to start utilizing this data to hopefully improve our patient outcomes. But that concludes mine, Heather. I hope I answered a lot of your questions.
Yes, that was wonderful. Thank you both, Josh and Kevin, for great information. Before we move forward into the question and answer portion, let me remind you how to get your certificate of completion. So for continuing education for nurses and respiratory therapists, this activity has been approved for 1 hour, 1 contact hour. Go to www.saxtesting.com/REV. You'll need to register on the test site, complete the evaluation form, and upon successful submission, you'll be able to print your certificate of completion. And support for this educational activity has been provided by Zoll Medical Corporation. There is an archive and on-demand version that will be available at www.revive-now.org. The on-demand version will be accredited for nurses and respiratory therapists. All right, so let's get to some of the questions, and we do have several. We'll start kind of short and sweet here. We had a question from Terrence. Says, Josh, what would be your advice to a unit looking to start improving ventilation quality?
Yeah, my advice would be to get the sensor. They're not that expensive, and start collecting some data on that. And I think you're going to be shocked at how difficult it can be. You start to lose focus, and you start to think about other things. And the next thing you know, you're ventilating the patient at 20 times a minute, or maybe you're not given the correct volume. CPR, they got the cool songs like Staying Alive, Staying Alive.
Right.
There's nothing cool for ventilation feedback. There's not a song that slow. So I think you'd be shocked at, you know, it seems like such a basic skill. This was like the first skill that we started This is the first skill that we all started getting trained on. It was, all right, ventilate the patient once every 10 seconds, squeeze the bag, and then you start asking questions like, well, how hard do I squeeze the bag? You know, or how light should I squeeze the bag? We've learned that looking for chest rise isn't the best indicator because we're all built a little bit differently,
Right.
especially when the patient's positioned in a different way. They're flat on their back. Maybe they have a barrel chest. Maybe they have kyphosis. Every patient's a little bit different. So once you start collecting actual quantifiable data, you're going to see a baseline of where you need to start.
Awesome. And I do think it's important across the continuum and healthcare in general to collect data. If you want to see positive change, whether it's to improve your ventilation outcomes, whether it's for some medications or a PI project that you're doing in your facility, data is so very important. And this seems like a great device to help everybody get data to move in a positive direction. All right, so our next question, let's see. This type of ventilation feedback is this something that can also be used in a NICU, or is this primarily for a larger patient population?
This particular one that's been talked about today is for adult patients only.
Okay, very good to know.
I think
Maybe
it goes.
NICU is
Yeah,
not
you
my
can
thing, so.
You can change the tidal volume, I believe, and I'm not 100% sure. It depends on the type of sensor that you get. The volume does not go down for pediatric patients at that time for this sensor that we're talking about.
Okay. All right. Let's see. What cord is that hooking into, and is that a separate attachment? That's from Cassie. I think she's referring back to the video that one of you showed.
Yeah, so again, that's specific to the device that's used in the video, and I guess that it's specific to that. So it's the cord that would actually go to, it's proprietary to the company that's shown.
Okay. Let's see. Somebody commented, this has been great for an in-hospital clinician. Wonderful to hear that. Somebody else commented, as an RT, we tend to get a little excited when bagging. I think that's kind of across the board.
I think paramedics and EMTs do the same thing.
Yes, yes. Another question.
We are truly all guilty, unfortunately. Like Josh and I have said a whole bunch of times, it's super basic. But if you were to go, if any department within a hospital took one bag valve and a timer and went into a room and individually told a person to bag somebody, a normal adult male, or anybody at the rate that they thought was appropriate, and didn't give them a timer and didn't give them anything except for their mind and their hand, they would be probably overventilating or underventilating. And it's a simple way to get some data. That's regardless of the tidal volume. Now we're talking about tidal volume. How much are they squeezing? What's their muscle memory on squeezing the bag? So I recently did something similar to this, and just watching our folks from all over the county. It wasn't even just my folks, it was all over the county. I thought to myself, we have a lot of work to do.
Yeah, absolutely. Another couple questions. So does the ventilation feedback device also measure the end-tidal CO2?
No, that was a separate sensor. It does not measure end-tidal CO2. It's part of the airway stack that we use. So we use an iGel or an endotracheal tube. And then we use a sensor, the ventilation feedback sensor, and then the end-tidal. So it's a separate sensor.
Okay, so theoretically, you could, if I could literally stack them up. You called it a stack. Literally stack them.
Exactly what we do. It kind of gets a little bit long.
Yeah. Okay. Is the ventilator feedback device only compatible with certain types of Zoles? Did it require the most recent version of Zole?
So it's only compatible on the X Series Advanced, and if you have BVM help.
Okay. Is there a graph showing live status during CPR that gives exhale tidal volume so you can increase or decrease on demand?
You can adjust the tidal volume on demand, but there's nothing that talks about exhalation.
Okay.
Did I hear the question right? Did you say something about exhalation?
Yes, asking if they could, let me read it again. Is there a graph showing a live status during CPR that gives exhaled tidal volumes so you can increase or decrease on demand?
Half of that, yes. You can see what you're giving as far as live tidal volume, nothing on exhalation, and there's no graph.
Okay.
Go back to that video that I showed of Mike squeezing the bag, and it shows the volume that's being displayed. And I believe it says like 485 milliliters on his first squeeze of the bag there. So that's the information you're going to get displayed on a Zoll, on the Zoll monitor. Yeah, here we go. So that's the information you're going to get displayed. It doesn't display in a graph form or anything like that. But, and then if you wanted to configure the ventilation or the volume differently, you can increase or decrease that depending on what you want.
Okay.
But yeah, this is exactly what it'll display on the monitor when you're on a patient. The graph and everything that I was showing you at the end through the QA/QI software, that's the software we use for training purposes.
Okay.
Here it is. Zooms in. Like I said, the first squeeze. Oh, there we go. It displays the information automatically there, and it'll give you the volume. And then that little bubble in the middle, you see how it shrinks down? That's when it prompts you to provide the next breath. I hope that answered your question. I'm sorry.
All right. I think we have time for another question or two. Let's see. You had mentioned in the presentation that it was fairly cost effective. Is that correct? Just thinking of the area that I'm at, it's a rural hospital. It is a regional facility. So there are much smaller facilities closer to myself. I'm sure there are across the nation. How cost effective is this device? Because I know everybody's looking at the nickels and dimes so that we can survive in today's economy.
I think that there's no such thing as something that's affordable in healthcare.
Amen.
Supplies specifically. So I think it goes down to what is a life worth? I know that's a tough debate. Everything costs money. I will say that if you really look about the long-term effects of things, if you're able to save a patient, specifically in a hospital setting, that means that there's a patient that you can take care of tomorrow, the next day, and the next day. For the minimal price that these do cost and the upgrading of your monitor, I think that it pays for itself with those extra days of care within the hospital setting. I hate to relate money to patient care. I think that in order to be really, really good, we have to spend a lot of money. Fortunately for the world, we're only spending about 3% of our calls are cardiac arrests, and probably less than that in some jurisdictions. So spending a lot of money to save those folks, which we're really not that great at percentage-wise. If my kid came home with a 56 or a 62% grade on her geometry class, I wouldn't be happy with it. But if we have 62% ROSC or we have 20% survivability, I'm happy with that. I'm happy with those failing grades. But to go back to the money, nothing is cheap. But Josh did say cost effective. I do think for the money, the value is there to be able to give us some long-term effects and great data to be able to say that we're doing it poorly or good.
Okay, I think we can do one last question. From my understanding, the American Heart Association expressed that during CPR, circulation is more important than ventilation. How do we take this feedback to equate its importance to standard CPR care?
I think a lot of the studies that are being done are going to drive us back to equating ventilations to compressions. Again, AHA guidelines are a guideline. So if you know that there's plenty of studies out there that prove that appropriate ventilations improve cardiac arrest survivability, you should probably start implementing that into your protocol.
And I think, again, it goes back to data. If you want to have positive change, you got to have the data, and y'all have presented the studies, and the data's there. Get some help from your quality department and collect data at your own. And I have been told we have time for at least one more question. Let's see. We've talked about that. Do y'all by chance have a list? This is specifically requesting post or provide the companies that sell the bag mask, the valve, the BVMs, sorry. I don't know if y'all have just some resources in general that you could share.
We could probably share that after the class. We could probably come up with something.
Okay.
No, just touching on your last point, Heather, though, the data, I mean, that's how we started down this journey, because we were trying to collect our ROSC data and figure out what our rates were and stuff like that. So then we started to hone in on the skills that we provide as paramedics and EMTs, as nurses and respiratory therapists. How can we be as consistent as possible? Like I mentioned earlier, if we have a patient last week and we accidentally hyperventilated them the whole time and we got a terrible outcome, we want to learn from that and improve from it. If we had a patient 2 weeks ago that we had great ventilation, great CPR, we gave just the right amount of medications, whatever that was at that time for that patient in that scenario, we want to learn from that and we want to keep doing that. So we're kind of in this process to where we're just trying to collect data and figure out the best way. Like Kevin mentioned at the beginning of his presentation, the standards and methods change over time. And we're kind of at this point, this pivot point where we're starting to get this technology, collecting the data and seeing what works best for our patients. But I know some of the founding principles of a cardiac arrest, good ventilations and good CPR, I don't think those are going away anytime soon. So
Correct. Absolutely. All right. Wonderful. Looks like we have hit a variety of the questions that we have available for today. They were asked in a couple different manners, but I feel like we've hit most of them. So at this time, I will turn the session back over to Tracy. Thanks everybody so much for attending.
Thank you, Heather, and thank you, Josh and Kevin, for that excellent presentation. As you can see, we like to thank everyone for attending today's webinar. Immediately upon the conclusion of this webinar, you will be presented with an online survey. So please keep your web browser open and we appreciate your feedback. The CE Certificate of Completion, in 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. For nurses and RTs, www.saxtesting.com/REV. And again, we'd like to thank our speakers for such a fabulous presentation today. This ends today's webinar, and we hope you have a great rest of your day. Thank you.